The coronavirus are um, envelope positive stranded RNA viruses. Coronavirus responsible for COVID-19 is called the beta coronavirus. It's the same category as the severe acute respiratory syndrome virus, as well as the severe bat coronavirus, but in a different category. So the coronavirus study group, or the International Committee on Viruses, named this virus that we're in as SARS-CoV-2, which is called the severe acute respiratory syndrome coronavirus 2 in the year 2019. The Middle East respiratory syndrome virus, which is also another beta coronavirus, appears to be looks like SARS-CoV-2, and the closest RNA sequence that is similar is to the two bat coronaviruses, and it appears that bats seem to be the primary source, but then, transmitted directly from bats or from somewhere else is unknown. So today I'm going to discuss COVID-19 in children. There's a lot of discussions already on COVID-19 in adults and incidences. And since I take care of children, I want to talk about COVID-19 in kids. Good day to everyone and to the kababayans around the world. Assalamu alaikum, namaste, marhaban. Thank you for those who is here on this channel and who will be watching this as well. And ultimately, if this is your first time, my goals for having this YouTube channel is to share every bit of my knowledge relating to balancing life, work, and family. I'm not expert, but most of my knowledge I obtained came from the life experiences, the Dalai Lama, and of course the Sadhguru, and to all my mentors throughout my career and my life. Life is not all about physical aspects of life, but what makes it balanced is how you want to make it. Topics that I'm going to discuss in this vlog are: what is COVID-19? What is COVID-19 in children? What are the current trends regarding COVID-19 in kids? Articles, and there's a lot of them. Current assessments and interventions. What are the current clinical guidelines standards? How is it relevant to medicine and advanced nursing practice? And what is the future of COVID-19 in kids? So coronavirus is one of the human and animal pathogens that is an enveloped positive stranded RNA virus. It has different types. Some of them were the MERS-CoV and the SARS-CoV-1, which have the beta coronavirus, same thing as COVID-19. For familiarity purposes, RNA, which stands for ribonucleic acid, acts as a messenger. This comes from the body, bringing or encoding instructions from the DNA helix. The DNA stands for the deoxyribonucleic acid, for controlling the synthesis of proteins, bringing the genetic code. So for instance, if your dad has blue eyes, so the blue eyes will be expressed from the DNA of your father. So to be exact, it's in the chromosome 15 and in the P protein. And then it's expressed to the children or their grandchildren, to make a simple example. Although geneticists of note figured out that the expression of the eye color can be more complex than this, but just wanted to give a simple example. So the DNA stores and transfers genetic information, and while RNA acts as a messenger between DNA and ribosomes to make amino acids and proteins. So viruses use either DNA or RNA as genetic material, but they require the host cells to replicate. Anyway, COVID-19, which is the SARS-CoV-2, is a new virus caused by another strain of virus called the beta coronavirus, just like the MERS-2 and SARS-CoV-1. It started in 2019 in Wuhan, China, and it spread throughout the world, making it a pandemic. So this was called and named by the Coronavirus Study Group of the International Committee on Taxonomy of Viruses. So the host receptor for SARS-CoV-2 cell entry is the same as for SARS-CoV-1, the angiotensin converting enzyme 2. So the host receptor or the receiver for SARS-CoV-2 cell entry is the same as for SARS-CoV-1, as I mentioned before, the ACE2. So COVID-19 binds to ACE2 through the receptor binding gene region of its spike protein called the S protein. So to explain simply what ACE2 is an enzyme or a catalyst of the renin-angiotensin aldosterone system that acts by converting angiotensin 2 to angiotensin 1 to 7. And to keep it simple, the renin-angiotensin aldosterone system plays a critical role in controlling your cardiovascular and your kidney functions. So ACE2 is an important regulator of this system. In healthy state, the ACE2 maintains a balanced or homeostasis between the angiotensin 2, and during this time, you constrict your vessels, the inflammation, you have fibrosis or scarring, and proliferation or production. And the angiotensin 1 to 7 pathways vasodilates, anti-cell death, anti-scarring, and anti-production. So if ACE2 is not maintained, it can be seen definitely in lung injuries caused by RSV, also called RSV, respiratory syncytial virus, and the avian flu H5N1 infection. The transmission of COVID-19 is, of course, direct person-to-person respiratory transmission, and the potential to transmit COVID-19 begins before the development of symptoms and is highest early in the course of illness. And then environmental contamination, it is unknown how long COVID-19 can persist on surfaces. Other coronaviruses have been tested and they can survive on inanimate surfaces for up to 6 to 9 days. And then the risk from animal contact. COVID-19 infection is thought to have originally been transmitted to humans from an animal host, but the ongoing risk of transmission through animal contact is uncertain. So there's no evidence suggesting animals, including domesticated ones, are a major source of infection in humans. And then, of course, like other viruses, COVID-19 evolves over time and now with different variations. So how does COVID-19 affect children? Back in March 2020, little was known about the pathogenesis of COVID-19. And then as kids got more infected or affected, there were a couple of researchers that wrote, for instance, Dochak et al. In India. What they found in that COVID-19 affects children at a less severe version than adults. For example, fever of 3 days in children compared to 10 days in adults. And if they're hospitalized, they usually have comorbidities like any gut problems like the intussusception and multi-organ failure. A case in China, a 10-month-old from there who passed away. Speculated reasons for mild cases in children and adults is that the expression of primary target receptor for COVID-19, ACE2, decreases with age. And then second is that children have strong innate immune responses due to trained immunity, leading to probably early control of infection at the site of entry because of all the vaccines they're getting, and also the incidences of frequent viral infections. Number 3 is that T helper 2 immune responses help protect children. The T helper cells have 3 things. The T helper 1, 2, and 17. And then the T helper 2 specifically is driven by the interleukin 4, 5, and 13. And what they do is they reduce ACE2 in the lungs, and this results in better outcomes with COVID-19. Number 4 is the eosinophilia associated with T helper 2 can also help. The T helper 2 cytokines increase a cell type called eosinophilia in the blood and tissues, and that eosinophilia is like a hallmark of this T helper 2 inflammation in the airways, specifically seen in children with asthma. So at least for now, what they found is that the T helper 2 inflammation may predispose children to experience better COVID-19 outcomes through a decrease in airway level of the ACE2. that overrides any countervailing or balancing outcome from high expressions of the TMPRSS2. The TMPRSS2 is an endothelial cell surface protein that is involved in the viral entry and the spread of coronavirus, i.e., COVID-19. So, if you have low levels of eosinophilia, you are more at risk of having a severe case of COVID-19, and also seen in the MISC patients where the T helper 2 levels were low. And this I will describe later on in the vlog. And then number 5 is that so children usually produce lower levels of inflammatory cytokines secreted from the immune cells. So they have an excellent regeneration capacity of their alveolar epithelium and may be contributing to their early recovery from COVID-19. So the clinical findings for COVID-19 in kids, overall symptoms are milder than adults. From 0 to 9 years old and 10 to 19 years of age, symptoms are almost the same with the exception of loss of smell or taste, since older kids can verbalize a lot more. So signs like fever, cough, shortness of breath, muscle pain, which is called myalgia, rhinorrhea, which is runny nose, sore throat, headache, nausea and vomiting, abdominal pain, diarrhea, loss of taste. And for someone who's less than a year old, also look for bronchiolitis and difficulty feeding to add along with the rest of the findings. They don't need to have all of them, but 1 or 2 always suspect COVID-19. So lab values, CBC usually are normal, but on the study they found that 17% had low white blood cell count, 13% had neutropenia or lymphocytopenia. The inflammatory markers like the CRP and the procalcitonin, I didn't include here, but ESR as well, can be a marker for multi-system inflammatory syndrome in children, which is called MISC. They also found that interleukin-6 ferritin D dimer to be elevated as well. They also found that creatinine kinase were high in 15% and that serum aminotransferases were high in 12%. For imaging, there were for imaging meta-analysis of 1,026 children. They had CT of the chest. 36% had normal findings and 28% had bilateral lesions. The ground glass opacities they found 37%, and that consolidation of or the mnemonic infiltrates found 22% were most common. Ground glass opacity X-ray, usually found in patients with pneumonia or pulmonary edema. For other viral symptoms in imaging, there were no hyperinflation and peribronchial markings. In Italy, 8 children were studied and found to have subpleural consolidations or confluent B-lines, which were also found similar to adult imaging via the use of ultrasound, which are the lung consolidations. Usually they are considered artifact, but if they're found, they usually represent pulmonary edema. So the current statistics from COVID-19 preliminary data from as of February 6, 2021, from March to November 2020, they found 807 cases between 0 to 40 years old, 1,344 from 5 to 17 years old, and of course there's 587 between 18 to 49 years old incidences. Also, they found that there are male and female incidences for hospitalizations are almost the same, and also pediatric associated COVID-19 medical conditions were associated with a higher level on the unknown, which was 47.4%. And the other high one is obesity, which was 37.3%, and then hypertension and immunosuppression, and the other ones are all in a very low percentage. Multi-system inflammatory syndrome in children. So the clinical features similar to those of the atypical Kawasaki disease. Kawasaki disease shock syndrome and toxic shock syndrome. They are in a febrile inflammatory state. They have Kawasaki-like illness, and if they have both, it's called severe MISC. As a background, Kawasaki disease is an acquired cardiovascular disorder, previously called mucocutaneous lymph node syndrome, which usually affects children younger than 5 years of age. It is a self-limiting condition with fever and inflammation that can last for about 12 days without treatment. However, the disease can affect the blood vessels without intervention and lead to cardiac devastation, such as coronary artery abnormality and ischemic heart disease, resulting in sudden cardiac death. So the disease will have complications of coronary artery aneurysm, which are usually about 8 millimeter in size. And also, Kawasaki disease can lead to myocarditis, myocardial infarction, arrhythmias, and peripheral arterial circulation. And with the treatment of intravenous immunoglobulin IVIG, in conjunction with high dose aspirin, the incidence of Kawasaki disease can dramatically decrease the incidence of the development of aneurysms. So, the multisystem inflammatory syndrome in children, MISC, is a febrile inflammatory state. The signs and symptoms are persistent fever lasting for 5 days, headache, fatigue, and atypical Kawasaki like signs and symptoms. They must meet 4 of the 5 criteria. One is the bilateral bulbar conjunctival injection. Second is the oral mucous membrane changes that are like injected or like they have fissured lips, a strawberry tongue. The peripheral extremity changes like redness of the palms or soles, swelling of the hands or feet in the acute phase, and then a periungual desquamation in the convalescent phase. They also show polymorphous rash and then a cervical lymph node lymphadenopathy, at least one affected, and they're usually about a size of 1.5 centimeter in diameter. So a study done by Bardar et al. Did a meta-analysis systematic review that out of 314 found articles, 16 articles with a total of 600 patients were included in the study. And the most common presentation was fever, which was 97%, followed by GI symptoms, which was 80%. Skin rashes were 60%, as well as shock, which was 55%. Conjunctivitis was 54%, and respiratory symptoms were 39%. The less common ones were neurological problems, which was 33%, and skin desquamation, which was 30%. And so the MISC was also slightly more prevalent in males, which was 53.7% compared to females, which was 46.3%. The findings of this meta-analysis found that the common clinical presentations of COVID-19 was associated with MISC include a combination of fever and mucocutaneous involvement similar to atypical Kawasaki disease and multiple organ dysfunction. Fever is the hallmark of Kawasaki, and so does MISC. But much worse, they revealed that 55% of COVID-19 with MISC had signs and symptoms of shock. There were pericardial effusion, half of them had it, and 57% had myocarditis. The coronary dilation is another one, decreased left ventricular function. And from the studies, they also found that 37% needed non-invasive ventilation. 32% did need the ventilators, and 8 patients passed away. So mortality rate was 1.33%. So they suggested that labs should be drawn. And so anyway, due to the relatively higher morbidity and mortality rate, it is very important to diagnose this condition promptly. And ultimately, then if a child comes in with fever, Kawasaki-like illness symptoms, and mucocutaneous involvement, always suspect MISC. The current treatments, assessment, and intervention, of course, we already know the lab PCR swab test, outpatient testing in clinic, and drive-through testing if the child has symptoms, assess the severity of the disease from mild to severe, and the need for oxygen. Tylenol is used as an antipyretic medication. It's for fever, and NSAIDs can still be used. There were uncertainty about the NSAID use. There was a minimal data informing the risk of the NSAIDs in the setting of COVID-19. The European Medicine Agency, World Health Organization in the United States, NIH COVID-19 treatment guideline panel do not recommend that NSAID be avoided when clinically indicated unless there is gastrointestinal bleeding. The next one is that if the child is on asthma medication, they need to be in a good asthma control. And for patients with COVID-19, inhaled asthma medication should be given by inhaler rather than nebulizer when possible, to avoid aerosolizing the virus and enhancing the spread of the disease. And then if you on ACE medication, which are the angiotensin converting enzyme like lisinopril, to control blood pressure, there has been a speculation that patients with COVID-19 who are taking these medications have high risk for adverse outcomes, but found to not be supported by any observational studies. So hospitals patients are given supportive therapy like IV fluid, antibiotics. If patient has pneumonia labs, thromboprophylaxis to prevent the risk for clots or called venous thromboembolism. Antiviral therapy is decided on case-by-case basis. For instance, remdesivir in a child that cannot be enrolled in a clinical trial, and if they are, they need to be about 12 years, more than 12 years old, and weigh about more than 40 kilo. The duration is 5 days. The remdesivir is contraindicated with hydroxychloroquine and chloroquine. The remdesivir with baricitinib, used for rheumatoid arthritis, it is used as an emergency use for children more than 2 years old with high oxygen requirement or ventilatory support. It is used in a context of a clinical trial. Also, the hydrochloroquine should not be used in children unless in a clinical trial as well, and avoid it with someone who has electrocardiogram problems like the QTc abnormalities. And the next one is the glucocorticoids. They are used and decided individually for immune-mediated complications of COVID-19. The further current treatments and assessment intervention is the outpatient triage. The CDC has a telephone triage guideline for children who are more than 2 years old. Second is that no outpatient monoclonal antibody therapy in the outpatient setting, if employed or given, ideally should occur in a clinical trial and should consider risk factors. Management is focused on prevention of the transmission to others, like isolation and monitoring for clinical deterioration, and of course, supportive care. Current clinical guideline standards in our assessment tool. The telephone triage is found at the CDC. There's a lot on the National Institute of Health website, also the World Health Organization website, and for healthcare workers, there's a lot of information from the CDC website. The telephone triage, the algorithm is for kids who are more than 2 years old. Number 1 is greeting. Number 2, start the triage and evaluate for life-threatening conditions like, are you sick? Find out how old they are, the condition, signs and symptoms, screen for any exposures and symptoms, assess for any high-risk conditions or medical conditions, screen for special circumstances like special healthcare needs, homelessness or long-term care facility, and then provide appropriate disposition. So next one is, how is it relevant to medicine and advanced nursing practice? Everybody knows that it's relevant, and that not only that we manage children in the inpatient setting, but also in the outpatient setting as well. Researchers from China, from 3 hospitals, were trying to figure out early on the incidences of COVID-19 and its transmission, and also they wanted to find out how we can avoid getting infected. And so they, as we already know, face mask, face shield, washing hands. So healthcare providers and the patients, the healthcare providers should always be prepared to answer questions. A lot of the information are found in the CDC website. Consider clinical presentation and triage accordingly. Continue with the well child visits and encourage telemedicine. And newborns should be seen in person for feeding, weight check, dehydration, jaundice, and also screening. So what is the future? Lung specimens from like early COVID-19 in 2 patients with lung cancer early on showed some proteinaceous and fibroids with mononuclear inflammation, giant cells, And that post-mortem specimen from 3 patients dying of acute respiratory failure on day 1, 6, and 2 weeks of onset of respiratory failure, they also found showed features of like alveolar damage, hyaline bodies, and type 2 pneumocyte hyperplasia, and occasional thrombi. So these findings are similar to findings of SARS-CoV-1. And then the immune staining from SARS-CoV-2 showed strong staining of the alveolar epithelial cells. And these findings of strong virus staining of alveolar cells with few immune cells point more toward direct virus-mediated cell injury. So the future is that there should be more post-mortem biopsies at different durations of the illness, and that the pediatric autopsies and biopsies will provide additional information. And second, of course, vaccines and treatments. Studies describing immune pathogenesis in COVID-19 are lacking in children and need urgent attention. As a summary, children are protected from severe COVID-19 due to prevention of virus exposure, appropriate infection handling, absence of risk factors, and high-risk groups are infants less than a year old and pre-existing conditions. Also, strain immunity, they have strong innate response due to live vaccines and frequent viral infections. They have a high ACE2 expression metabolizing angiotensin 2. Lack of immune senescence, good lung regeneration capacity, and also the absence of high risk factors, absence of aging related comorbidities like obesity and smoking. Thank you again to everyone. I'll see you guys again in the next adventure.